get started. Thank you all so much for your patience. So without further ado, Dr. Chandra Ford.
Good morning. Good morning. I want to thank you all for this privilege of being able to offer a few remarks to you this morning. I'm delighted to be here. I want to acknowledge some of the folks I most admire in academia, starting with Dr. Sandy Garrity. I thank Dr. Pearson for the invitation, Addison Malone and Dr. Salima El-Amin, and the others for their work organizing this event and facilitating my trip. The title of my talk is Racism in Health, Considerations for Building a Research Agenda and a Movement. So over the last 20 years, the number of studies explicitly examining the relationship between racism and various health outcomes has grown rapidly. The field now has a critical mass of health equity researchers interested in examining racism's contributions to health disparities, but it lacks a cohesive vision of the goals and mission of this area of public health. So in today's talk, I briefly assess the state of the evidence linking racism to health inequities, and I highlight examples from the work on HIV/AIDS. Next, I propose a two-part research agenda to help move the field toward both producing needed empirical evidence and addressing racism's role in health and society. Finally, I raise several key challenges the field must confront in order to make progress on this agenda. Though there are no simple answers to these questions that I'll be raising, it is critical, I believe, for the field to grapple with them. I was pleased to learn that this audience includes undergraduate and graduate students, as well as faculty and staff, and my remarks are intended to engage all of us in conversation today, throughout the day, in this Q&A, and also throughout the day. So just a couple of basics before we proceed. And these coming from the World Health Organization, we can think of health as the state of complete physical, mental, and social well-being, and not merely the absence of disease. And the goal of the field of public health as being optimal health for all, with the emphasis on the all piece being where we focus in terms of addressing equity. And we can think of social determinants of health as the environmental and social conditions, such as poverty, that lead to high rates of preventable disease and inequities. Now, research on the health of racial and ethnic minority populations has been ongoing in the field of public health since at least the mid-20th century, and that is if we don't count the sort of medical racism forms of racism, forms of research that existed well before then. For the most part, this work on minority health, as it was once called, primarily sought to address the disproportionate burden of disease that racial and ethnic minority communities experience as a result of socioeconomic disadvantage. In the mid to late 20th century, studies on health disparities may have acknowledged that minorities exist within a social context where racism exists, but they rarely focused on directly estimating the effects of such racism on health outcomes. Exceptions to this tendency could certainly be found. For example, in 1973, Castellano-Turner and William Darity Sr. published a paper in the American Journal of Public Health in which they reported findings from their study, which was entitled Fears of Genocide Among Black Americans as Related to Age, Sex, and Region. And in that paper, they argued that, quote, fears of genocide among Black Americans are firmly based on historical and contemporary reality. Black Americans have been subjected to centuries of brutalization, which needs no documentation here, but more importantly, the pervasiveness of white racism in the U.S. continues to create the circumstances for both direct and indirect forms of Black genocide, unquote. So that's an exception to the rule. In general, however, the explicit study of racism as a social determinant of health disparities is a relatively new area, and it builds on the foundation laid by generations of researchers and practitioners who pushed the field little by little toward acknowledging racism exists and then taking seriously studies that examine it. Since the 1990s, public health has made substantial, albeit uneven, progress toward documenting the prevalence of various forms of racism and the relationship with a number of health disparities. And the state of the evidence linking racism to health disparities is stronger than it ever has been. So the number of studies examining specific types of racism, for instance, discrimination, and estimating the effects on health has grown rapidly over the last 2 decades in particular. Researchers now enjoy a generally supportive climate within the field for studying racism as a social determinant of health, so thinking about social determinants of health as racialized. The high level of support for work on racism research is evidenced by at least 3 factors. First, the NIH now regularly solicits proposals that explicitly call for studies of discrimination or racism relative to health, right? So that's evidence that concerns about racism can be studied within the field. Secondly, the Institute of Medicine has published a seminal volume looking at discrimination and its relationship to health disparities. And I'm involved with a committee now at the Institute of Medicine that is taking very seriously the ways in which racism might be addressed in order to promote cultures of health in communities. So these are central organizations to which we turn and who are saying, we need to focus on racism, excuse me, as a part of addressing health. Finally, the field's flagship professional organization, the American Public Health Association, is led by an African-American woman, Kamara Jones, who established the Measures of Racism Working Group at the Centers for Disease Control and Prevention, okay? And she's also published what she would call racial equity allegories in the scientific literature. Moreover, in her role as president of APHA, she has declared that the organization's primary agenda during her tenure will be to lead the nation in making substantial progress toward the elimination of racism. This literature on racism and health primarily focuses on such outcomes as mental health, cardiovascular, birth or pregnancy-related outcomes, and increasingly on healthcare provider interactions with the healthcare system. And there's even work coming out of psychology that looks at neurological activation if people are exposed to particular racialized cues. The major forms of racism that this literature examines are primarily those tied to interpersonal discriminations, for example, being treated unfairly by someone, and to a lesser degree, segregation. A number of systematic reviews have been published recently. They generally find that however racism is assessed, whether it's one's prior experiences with discrimination, the implicit biases of their providers, or in other ways, it is associated with worse health outcomes. Factors known to affect this relationship include how people cope with any racism that they experience. The data are mixed on how socioeconomic status influences the relationship between racism and health. Relatively few studies also have sought to clarify gender differences, although some data suggest the effects of racism may differ slightly for men versus women. I believe, though, that part of this might have to do with how we measure discrimination, and many of the measures reflect ways that racism operates for men. Probably that's my suspicion, just evaluating those measures. In order to give a concrete example of the potential relevance of racism to health, allow me to call your attention to an area in which I have worked for some time now, and that is the U.S. HIV/AIDS epidemic. HIV/AIDS remains a major public health issue in the U.S. More than 1.2 million people are living with HIV infection, and approximately 40,000 new cases are diagnosed each year. And President Barack Obama was the first president to establish a White House Office of National AIDS Policy. In 2015, that office updated its national HIV/AIDS strategy to emphasize health equity among the populations most impacted by HIV/AIDS. And the vision for this strategy is as follows. The United States will become a place where new HIV infections are rare, and when they do occur, every person, regardless of age, gender, race or ethnicity, sexual orientation, gender identity, or socioeconomic circumstance, will have unfettered access to high-quality, life-extending care, free from stigma and discrimination. So the U.S. HIV/AIDS epidemic is an exemplary condition for exploring the relevance of racism to health disparities. This chart shows racial ethnic trends since nearly the beginning of the epidemic in the U.S. in the proportion of diagnosed AIDS cases from 1985 to 2014. Now, AIDS is the end-stage condition of HIV infection, and it's useful to think about patterns of AIDS because in a country where access to HIV care and HIV medications is widely available, for people to progress from HIV infection to AIDS is really a signal of the failures of the healthcare system, right? Or their inadequate and not timely access to HIV medication and care. What I'd like to draw your attention to are a couple of things. First, if we look at the earliest point in this chart, 1985, African Americans represented about 12% of the U.S. population at that time. But if you look at this line here, which represents the proportion of AIDS cases, AIDS diagnoses among African Americans, you can see that even at the earliest point in time of the epidemic, African Americans represented twice our share of the U.S. population in terms of the share of AIDS diagnoses. This pattern continues in terms of this disparity, the disparity relative to our share of the U.S. population. And as we look over time, we see that actually African Americans in 1994 began to represent a greater share of AIDS diagnoses than did whites. So while AIDS diagnoses, our share of the AIDS diagnoses continued to increase over time, as you can see here. They actually decreased for whites, and in 1994, the proportion among blacks that was when it first began to exceed that for whites. What's interesting to think about is that this is also the time when, 1996, when HIV/AIDS medications, the highly active antiretroviral therapies, became widely available. Okay, so these data, the data that I just showed you, are not proof of a racism effect. However, they do raise some questions that might lead us to think about, are there ways in which racism might play a role in contributing to these patterns? So, although the antiretroviral therapies that are credited with extending life for many people are, excuse me, became widely available in 1996. One of the concerns that gets raised is whether or not there was equal access to these medications. And a study conducted by King and colleagues examined just that kind of question. Now, they did not intend to examine this in terms of racism. But what the study did, it was a national study based on a probability sample of more than 1,200 black and white HIV patients, all of whom were under the care of their providers, and they were followed over time. Researchers examined all relevant clinical factors, and they also linked the medical records information from the patients to information about each of their providers. And what did they find? They found that that among white physicians, that Black patients were prescribed the antiretroviral therapies later than similarly clinically situated white patients. Okay? There was no difference in terms of how long it took for patients to get the antiretroviral prescriptions among Black providers. All of these findings were statistically significant. I would say that the findings suggest the need for further research to determine if provider bias might actually help to explain these delays in accessing the protease inhibitors. So disparities such as these, while they do not provide evidence of a racism effect, together with other considerations, they do highlight ways in which racism might actually help to explain these patterns. So part of what makes HIV/AIDS a very helpful condition for studying racism is that first, HIV is considered a social disease. That is, that the ways in which transmission occurs, the patterns and the distributions that we see in populations, both reflect and they also can reinforce existing social inequalities. HIV/AIDS is not randomly distributed across all groups, rather it is distributed along racial lines and along other lines that reflect patterns that occur within largely segregated sexual and social networks. And groundbreaking work by Lauman and Young beginning in 1999 offered essentially a sea change in how we thought about high rates of HIV infection among African Americans. So they shifted the focus from what is it that Black people are doing, or what is it that are characteristics about Blacks that leads to their high rates of HIV infection, to shifting to understand what is a social context that might explain why people who engage at similar levels of risk behaviors might differ in their risk for actually acquiring HIV infection. And what they found is that sexual network segregation in the U.S. is starkest between Blacks and whites, and that for a variety of reasons, this led to more efficient rates of HIV transmission among Blacks than among whites. Another consideration is that African Americans, as well as other racial ethnic minorities, are disproportionately burdened by both HIV/AIDS and racism. So it makes sense to think about those two together. And then finally, racial ethnic minorities persist despite the fact that racial ethnic minorities appear not to engage in more risk behaviors or to engage in riskier behaviors. And this suggests that the disparities may be due in part to the racialized social context in which people exist and in which their behaviors occur. In addition to the forms of racism most frequently described in the overall literature on racism and health, and these are essentially the everyday racism, since much of that literature is based on mental health and stress-related outcomes, there's also a big emphasis on chronic exposure to everyday racism. There are some forms of racism that may be unique to HIV/AIDS, and in ongoing work with a former student of mine, Cook, we are evaluating the evidence that links racism to HIV/AIDS inequities. We have found some statements, such as the ones I'll show you momentarily, that are typical of some of the ways in which racism may uniquely influence HIV/AIDS prevention-related outcomes. So one set of authors in their study actually talked about this because in addition to what actually this was a common trend in this work, is that in addition to reporting their findings, some authors felt compelled to describe how salient racism and discussing racism was to the study participants, and they actually talked about that in their paper as well. And here, Timmons et al. Write, quote, "Some of the women believe that they had been directly targeted as victims and suggested that HIV had been placed in the African American community by a racist government and society, unquote. This point kind of reminds us that stigma continues to be tied to HIV in ways that it is not tied to other racism-related outcomes, other outcomes frequently studied in the racism literature, such as elevated blood pressure. Right? So there is stigma tied to HIV in ways that are racialized, that are not available to us if we only look at racism and health through, for instance, a cardiovascular lens. In another study by Malbrecht and his colleagues, among Black, gay, and other men who have sex with men, they were trying to understand these men's experiences in health. One focus group participant described it this way, quote, "Gays is AIDS. AIDS is a monkey. In the dark understanding of the virus, that's where it came from, monkeys. And the monkeys represent what? Blacks," unquote. So here you can see that he's tying together for us links between HIV/AIDS, sexual orientation, and Black race that are very, there's no ambiguity here. And then finally, in a study among transgender women in the San Francisco Bay Area, this participant describes, and this work was really to try to understand HIV/AIDS issues. This participant responds by saying, quote, "Many times one thinks that it is because one is transsexual, but the discrimination is because one is Hispanic," unquote. And in this study, it was a multiracial study, and people of various backgrounds, women of various backgrounds, talked about their experiences with racism. So to summarize the evidence on racism and health thus far, overall this literature is growing rapidly. The evidence generally shows that factors such as racial discrimination are associated with a variety of health outcomes. As evident from the HIV literature, there may be disease-specific ways in which racism contributes to some outcomes. So a two-part research agenda is needed, I believe, to address the impact of racism on population health by both advancing the science and developing a comprehensive response to structural racism. Based on the evidence currently available, I offer four recommendations for a research agenda that would aim to build the evidence to explain relationships between racism and health inequities. First, it's important to integrate overlooked health outcomes. So I just gave the example of HIV, but there might be other outcomes. HIV is my area, so I can say something about that. There might be other outcomes that are relevant that would improve our understandings of the relationship between racism and health if we could tap into those. Moreover, although we can think about the ways in which racism-based HIV conspiracy beliefs, which are really common in the literature that we're examining, we can see how that's relevant to HIV-related outcomes, right? But it's also possible that that HIV-specific racism variable might actually be relevant to non-HIV outcomes. For instance, stress or mental health, right? We also need to move beyond describing the prevalence of racism constructs. So many studies tell us how frequently people experience discrimination and those kinds of things. And moving beyond both the prevalence and its associations with specific outcomes, emphasis on associations, toward explaining the mechanisms by which racism causes the outcomes. And in the racism and HIV/AIDS literature between 1994 and 2014, for instance, 20% of studies provide rich insights through qualitative research. And of the 66% of studies on racism and HIV/AIDS related outcomes during that period, the vast majority of them do not permit us to draw conclusions based on temporality or other elements that would lead to stronger causal conclusions. Next, we can only identify causal contributions if we strengthen the methodological rigor with which we study racism. Similarly, improving the theory used to conceptualize race, ethnicity, and racism-related concepts is essential to understand fully and measure constructs that are as complex and at times as abstract as racism. However, if the field achieves this objective, it will have succeeded in providing strong evidence that helps us map the pathways linking racism and population health inequities. The second part of the agenda focuses on the fact that while the production of knowledge about racism is important for obvious reasons, our efforts to eliminate racism need not be constrained to the use of conventional empirical methods to produce evidence about racism's relationship to specific health outcomes. In short, we can draw on other resources and approaches in concert with our use of empirical methods in order to promote health equity. The desire to foster an anti-racism research movement is what motivated noted health educator Collins Iriangu and I to develop what we call the public health critical race praxis. And this praxis is one approach to public health research and practice that, while grounded in critical race theory, which originated in the field of law, is tailored and adapted to the empirical and practical needs of the field of public health. So it attempts to go beyond merely documenting health inequities in order to try to understand and challenge the power hierarchies that undergird them. Public health critical race praxis is also concerned with understanding how racialization might affect not only the health outcomes that are going on in our communities, but also the research processes used to understand those relationships. It offers two main resources: a semi-structured race-conscious research process, and I can talk more about that later, and a lexicon that helps advance theory and facilitate assessment of racial equity concepts. Each resource is grounded in critical race theory, but again adapted to address the needs and interests of empirical research and practical application within public health. So we describe it as praxis because it's an iterative methodology combining theory and experiential knowledge, science as well as action to actively counter inequities. A recent example of research conducted based on this praxis is presented here. Rayshawn Ray at the University of Maryland and Dr. Keon Gilbert, Dr. Rayshawn Ray and Dr. Gilbert at St. Louis University's College for Social Justice, for Public Health and Social Justice, are offering us a new way to think about, to conceptualize relationships between the various forms of violence, including death, that occur in the context of Black men's relationships with, or interactions with police. And endeavors such as these merge the two parts of the research agenda that I'm proposing, one building evidence and one promoting a movement, right? So not just limiting it. By shifting the frame through which we view disparities, enhancing the theoretical and methodological rigor used to study this disparities, and grounding the work in the social movements that are ongoing in our communities across the nation. However, this work is very challenging. Okay, so there are a number of challenges to studying racism and health. I'd like to raise just 3 of them today, and my hope is that it will help to provoke discussion, which I don't think we actually have any challenges having discussion this morning. While we were all sitting here, that continue throughout the day and hopefully beyond that, right, in the literature and in the work that we do. Some of these challenges are process related. How do we carry out this research in a manner that reflects the equitable relationships that we seek, equitable in terms of researchers and communities? Others are pragmatic, so let me just move to the first one. Racism is not a discrete exposure that can be isolated from the racialized social context in which we live and in which it occurs. Therefore, the field errs, in my opinion, in its tendency to treat racism as what I would just call for shorthand a typical public health risk factor, as something that is easily identifiable or as a treatable hazard that individuals can be taught to avoid. I believe it's more appropriate to conceptualize racism as an integral element of the social context in which all populations exist in this nation. And I can talk more about contextualizing the context of racism, and within which all research occurs. If the field recognizes racism as a structural force, then our efforts to eliminate it must be at least two-pronged. They must aim to explain how racism may cause disease. In addition, however, they must also help us understand how racism may influence the nature of our field and the impact our field has on society. So I think this tendency hampers our ability to do that well. Critical race empiricism, which is an emerging field that links the social sciences and public health with critical race theory and law. Critical race empiricism challenges the presumed objectivity of research and focuses more on identifying, acknowledging, and accounting for the subjectivities or biases that may influence our research. But this raises an important question of how do we do this in a field where I would call the myth of objectivity is pervasive? Further, does it serve minority researchers to disclose their biases? So if we're promoting the disclosure of biases and subjectivities among minority researchers, but this kind of orientation is not being advanced among non-minority researchers, does it serve the work of minority researchers to promote that kind of orientation, right? To differentially promote disclosure of biases. So how do we acknowledge the inherent subjectivity of research when our colleagues may insist their work is necessarily objective? What strategies can be used to increase awareness of the ways in which research is not objective and therefore may inadvertently contribute to disparities? One reason this question is important for people working with critical race theory is that it's difficult to meet the needs of quote-unquote objective empirical methods while at the same time rejecting the idea that empirical research is inherently free from bias. Historical analyses clearly show that bias, including racial bias, can influence research questions, a priori assumptions, which populations we're interested in, the conclusions that are drawn, the funding that's available. From a public health critical race praxis perspective, the systematic nature, So from a public health critical race praxis perspective, we draw a distinction between the systematic nature of research and its objectivity. And the systematic nature of research does not inherently render it objective and bias-free. It merely improves the reliability, and in fact, it might actually render any unacknowledged biases reproducible. I would argue that how objective empirical research is itself an empirical question that we can test. Other important questions that we need to ask include what methods are best for studying our research processes, especially when presumptions of objectivity are deeply ingrained. How do we begin to incorporate, assess, and legitimate researchers' experiential knowledge, right? So the ways in which our hunches or our life experiences inform the work that we do. The final challenge reflects a concern that I have shared in some ongoing and very thoughtful conversations within this emerging interdisciplinary area of critical race empiricism. It's important for us to be clear in that context of critical race empiricism, about the purpose of that work. And to the extent the purpose of the work is merely to document these racial patterns, I think that it raises this question for me. So our knowledge about racial phenomena has grown rapidly over the decades, as reflected and decreases in overt racist policies socially, right? Improvements in the rhetoric that people use, and improvements in social norms. Expansive bodies of theoretical empirical research now exist, and they document the existence of racism. They help to elucidate the mechanisms by which racism operates, and they begin to explain relationships linking racism to health or to social inequalities. But if people are indifferent about, let's say, Black lives, how much does the evidence matter? Or even does the evidence matter? And I don't want to be cynical, but let me just put this question out there, and hopefully people will, find a way to really tease this question out and challenge the cynicism that's kind of inherent in the question that I'm asking. The violence we are witnessing in our communities across the nation today is not new. Anti-Black violence by the police and others has been an integral part of the Black experience since the inception of this nation. And consider, for instance, the role of police violence in catalyzing nearly every racial uprising over the last century. Two things that are new, however, are our knowledge about racism. So we understand racism a lot better, and the strength of the evidence that links racism to various outcomes. We could look at social outcomes such as this, or health outcomes. It's not true to say that evidence has not existed in the past. However, often in the past, if Black people complained about police violence or other forms of violence, it was a he said, she said kind of situation, and so there was always a possibility of saying, well, we don't have enough evidence. Now we have evidence. The question I have is, despite the laudable gains that we've made, how much does the evidence matter? Despite the laudable gains, neither the strength of the evidence about anti-Black violence, the ease with which people can access the evidence, nor the improved understandings we have about racism are necessarily sufficient to yield convictions or indictments, for instance. And not that I'm actually encouraging reliance on what many call the prison industrial complex as a way of achieving justice. If our investment is in creating the evidence, how much does the evidence we produce matter? Based on recent trends and the Black Lives Matter movement, it seems that when the evidence suggests racism, the evidence may sometimes simply be ignored or explained away. In essence, empirical evidence may be no match for indifference about the value of Black lives. So the evidence exists, and evidence-based interventions could be implemented. The challenges that, the challenge may be that we need to create the will to use the evidence to address racism. So part of it would be not just evidence, but also what role do we serve if we think of ourselves as researchers and also creating something like a will. In conclusion, the evidence linking racism and health is growing rapidly and is certainly stronger today than it ever has been. Needed still, enhanced theoretical and methodological rigor to strengthen the evidence further. Expansion of the growing anti-racism movement within the field of public health and also linking it to what's going on outside of our field specifically. And the flexibility to respond to emerging challenges to health inequities. For convenience, I've placed here several links to the public health critical, if you're interested in learning more about the public health critical race praxis, about critical race theory, or to join the listserv. I'd like to make the following acknowledgments, and thank you. I'm happy to take a few questions if there are questions or comments.
Excuse me, can you go back 2 slides so we can get information about the listserv?
Oh, sure.
Thank you.
Yes.
So I guess I'm not, I really know like nothing about it. But I guess I study social science. So I know that the Black Panthers concentrated some of their campaigns on some public health efforts
Right.
in terms of like different, like genetic testing, things like that, sickle anemia, different public health campaigns. Do you think there's a place in the Black Lives Matter movement to also promote public health campaigns?
So the short answer is definitely, absolutely yes. Because public health is, especially social determinants of health, are really the conditions, in which we live. There are all these different facets of life. So to the extent we consider that public health, and these are the same kinds of things that organizations, well, movements such as Black Lives Matter are attempting to address. So absolutely, yeah. So part of what's implicit in your question is, how do people know what public health is? And many of us who are in public health actually didn't even know that we were in public health before we got in it. So I just wanted to say, many of us share your concern there. So I was actually an HIV prevention outreach worker, and I didn't realize that I was doing public health work before I learned that. So that's part of the challenge of our field, is to begin to connect to the broader society and to help folks understand what it is that we're trying to achieve and why it matters. Yes.
I'm actually a physician in the PH. I went to school in the 70s and then I went to the early 1980s because I'm interested in urban problems or inner city problems. I don't think there's social progress and public health are not necessarily synonymous. And I can tell you that the Harvard School of Public Health, where I was, we had a management course, and there was the whole tenor of the whole course. First of all, there's an oxymoron in terms of having a private school of public health.
It is.
And so the whole premise of this administration course was to develop a proper patient mix, or to demarket unprofitable healthcare services, or to develop a high value network, so that you. And basically, I took these as surrogates for demarketing services to poor, uninsured Black people.
Right.
And this was the basis. If you look at, let's say, the Harvard School of Public Health, and I think if you look at the profile of where these people end up working, they all end up working in HMOs to demarket the services that are not profitable or not going to meet the needs of our society.
So, I agree with you. This is what I consider to be part of the place where we are. That if our eyes are open to these injustices in our society, we can't just say they're out there in society and we'll study them out in society. We are actually part of the problem, essentially, and we need to understand how we might actually hamper the ability of our field to really achieve the visions of equity that we say we want. So I don't have an answer to that one, except I can say I share your frustration. Other questions? Well, thank you very much.